Yeah, thank you very much for that introduction. And thank you as part of the host. Again, let me use this opportunity to welcome everyone for all of the wonderful participation at the event so far. So it's an honor to be the moderator for this particular session. So I think the session is quite, the topic looks simple. Scaling digital health innovations, overcoming implementation challenges, and achieving sustainability. But I can always argue that those are three huge topics merged into one. Each and every one of them is something that you can discuss for a whole entire day. But I'm also glad that I have very competent, highly experienced list of panelists that are going to do justice to the above topic. So digital health, I think just to give a little overview, we have a lot of implementations. We've talked about that today. We have a lot of silo implementations, POC implementations, proof of concepts, and pilots, but very little scale. Even where we have scale, those skills are not necessarily sustainable. So that's why we are here, and that's why we coined up this topic, because it's something that really needs to be discussed. We'll be discussing some part of it in several other forums, but we thought today we could bring all of the experts here, relevant stakeholders, so that we can do real justice to the topic. So that's where we are. You'll be hearing of some of the challenges that include, of course, infrastructural issues, interoperability and integration issues, which we've talked about here, cultural insensitivity, and many, many more issues that have been spoken about, maybe inadvertently. But this is the time, the converging time, where these discussions will really hold today. So without further ado, I would like to start welcoming and introducing the list of my distinguished list of panelists. I'd like to start with Njide Ndili. She has already spoken, so most of us here, I'm sure we know her. She attends several conferences and forums and discussions like this. So she is the country director for PharmAccess. She promotes health insurance, innovative financing, quality improvement, business loans for health SMEs, and digital connectivity among patients, payers, and providers. She is also the Vice President of the Healthcare Federation of Nigeria, advocating for private sector involvement in healthcare. She is also a commissioner. She was a commissioner for the Lancet Financial Times Commissioning, and they had a very detailed report that I was opportune to have during the launch. I think that people seek that report. It's very comprehensive about healthcare implementation in Nigeria. So, and she's also a founding member of the Digital Transformation of Health Lab. Her qualifications include MSc from the London School of Economics, AMP from INSEAD, and MBA from the University of Houston, and BSc in Computer Science from University of Nigeria. Please, a big round of applause for. Thank you very much. Next on the list of our distinguished panelists, we have Dr. Ifunanya Ilodibe, who is currently the Vice President of Clinical Services and Chief Medical Officer at the EHA Clinics. With over 14 years of experience in clinical practice, healthcare operations, and quality management, Dr. Ilodibe is a seasoned physician leader. She began her journey at EHA Clinics in October 2019 as a practice and quality assurance manager, and played a critical role in setting up the COVID-19 Isolation Center and achieving JCI's accreditation for EHA Clinics in Kano. She was promoted to Vice President in 2022, where she oversees safe patient care delivery. She also holds medical degrees from the University of Ghana, a master's in international health management from the University of Sheffield, and multiple certifications in healthcare quality and management. Please, a big round of applause as we welcome Dr. Ifunanya. Very good. I guess you're already believing that when I told you I had a list of distinguished, qualified list of panelists that are going to do justice to this topic. And next I have Seun Adesina, Country Director of Viamo. Seun oversees the successful delivery and implementation of Viamo's projects, resource mobilization and partnership management with both private and public sectors. Before joining Viamo, he was the Associate Director for International Philanthropy at the International Rescue Committee and led private sector engagement for the USAID YPE4AH program at DAI, Nigeria. Seun has over a decade of experience in the private sector, including roles at InterSwitch, Fort Oil PLC. He holds degrees from the University of Lagos and Cardiff School of Business, with certifications from Oxford, Cambridge, and Lagos Business School. Please join me in giving a big round of applause for Dr. Seun. Yeah, and we have Chichi Aigbe, who is the Senior Project Manager at Reach Digital Health. She holds an MPH, Masters in Public Health from Rollins School of Public Health, Emory University, and an MD-CHB in Medicine and Surgery from Olabisi Onabanjo University Teaching Hospital. Chichi's expertise includes program management, digital health, operations, and stakeholder management. With extensive experience in international development, she has provided technical assistance and consulting for public health interventions across Africa. Currently, she oversees projects related to maternal and child health, sexual reproductive health rights, HIV treatment and adherence, and intimate partner violence, IPV. Please join me in giving a round of applause to welcome Chichi. I've already talked about the topic, scaling digital health innovations, overcoming implementation challenges, and also achieving sustainability all in one. It's an all-encompassing topic, like I said, 3 major topics in one. So the best way to start this will be to start with each of the panelists to see what they feel, what are their thoughts around this topic. But I want to, first of all, give us some quick ground rules, because I know how some of these panelist discussions can go at times. We talk about gender equality, we talk about so many things. So, and I'm glad that we have that well represented here. Maybe it's even tipped over, but that's okay for now. I also want to ensure participation equity, right? So please try to stick to the time. For instance, I'll be giving each and every one of you 2 minutes for the first introduction, where you give us what you feel about the topic. Try to keep to the time. That's the first ground rule. And when I raise up my hand, it means you have about 20-30 seconds to please round up, conclude whatever point you are trying to make, and not jump into another new point, please, so that we can participate actively. We need to carve out time for our engaging audience who are waiting online, and some are even here as well. So we really want the discussion to be very rich. And that's why I'm trying to apply some principles of equity here. So please try to stick to time as much as possible. So the first question is quite simple. You are free to talk, 2 minutes, 120 seconds, with the topic scaling digital health innovations, overcoming implementation challenges, and achieving sustainability. What your thoughts are, what you feel about the topic. We'll dive into specific questions later, but that's the first line of cue. So I'd like to start from my rightmost. And say over to you again. So please, round of applause for her once again, please.
Wait, the timer.
Okay, we've not taken lunch. It's breakfast. Well, didn't we have caffeine, coffee, tea? Please, a big round of applause. Aha. That's a lot better. Thank you. Thank you.
Okay, so I think it's a very important topic, which is very dear to my heart, because I consider myself an entrepreneur, a digital entrepreneur, and the challenge that we've had is really scaling. There's no point implementing a project that doesn't achieve scale. So we go by the principle of starting private and growing public, which is why I think that from the get-go, getting the input of all the different stakeholders is very important. As an NGO, trying to solve a problem with access to better healthcare, I have the opportunity to not be boxed into a specific innovation or a specific what I will call activity. So basically, how do you enable better access to healthcare, especially for the low and middle income communities? So that really gives us an opportunity to test different solutions, test different innovations. And for us, what I've found is that if you're not able to develop a simple solution that is scalable and sustainable without the input of government, who is a strategic purchaser, then you're going to have a problem down the line. I think that later I'll have an opportunity to give 2 examples of what I will consider highly successful innovations that have achieved scale. So I don't know how much time I have. I'm very conscious of not going over your limit, but one is, how do we ensure that there's interoperability amongst all the different innovations that are out there, which is why I talk about innovation and interoperability standards and having government champion that. So you can liken digital innovations and scaling it to maybe your iOS on your phone. Apple was able to develop that, but there are thousands and thousands of applications that plug into that iOS. So how do we develop a platform that we can plug into in the healthcare space? So health is one of those, industries where scaling of innovations is so way behind because there are certain principles that are still lacking, which is interoperability, ensuring that there is a strategic purchaser. It's not siloed. So we have to also, as we're designing, we have to ensure that the users of the system, that we get their input, because ultimately what we have is top-down approach, and the users, they don't even know why they're using the system. So they don't even adopt it. So let them see the bigger picture of the solution you're bringing, and then you're better able to get that result. So I think I'll stop there for now.
Thank you very much, Njide. I think that was quite concise, but I don't want to go into summarizing what you've all heard. I think we'll move quickly in the interest of time. Dr. Ifunanya, you will be next quickly.
Okay, thank you so much. And, just listening to Njide, I was just thinking, maybe I'd like to talk about this from the position of quality improvement. I mean, that's my field, right? And, at EHA clinics and some of the work that we've had to do, I think Dr. George said something: you cannot improve what you cannot measure. And really, when it comes to digital health innovation, for me, as a quality improvement specialist, it is the ability to use digital health tools to gather data that improve patient outcomes and, increase patient safety. And really, that has been a big challenge, because one of the things we talk about right now is stakeholder management, change management. You get these tools that you think, oh my God, this is going to change the game. And it's like, if you don't engage the stakeholders, they're just going to take the tool and keep it to the side, and they will just never use it. And, like we said, sometimes the top-down approach. So we go in with all these assumptions, thinking we have all the right ideas. And I think, there was this Dr. Ronke from, primary healthcare, that was saying, you just get these guidelines and they put it for you and say, use it. But then, they're made on faulty assumptions, which makes scaling very, very difficult. For me, I would say that where the opportunities are is making things as simple as possible. Data doesn't need to be complicated. The tools for improvement especially don't need to be complicated. As simple as a checklist that is easy for people to use. But one of the things that I see with primary care, right, we're a primary care facility, all the patients will not be managed in primary care. And we need to move these patients to secondary and tertiary care. How do we move the information that we've gathered? And how, as a quality person, can I guarantee that the patient who has experienced quality at my facility, there's a continuum of quality? You know, Njide has this, great tool, Safe Care, and they're trying to get other facilities to also look at quality. So it's beyond just thinking about how we implement these tools within my space. It is how can we continue quality care with using these digital tools. Thank you.
Thank you very much, Dr. Ifunanya. I think next on the line will be Mr. Seun Adesina. Thank you.
Thank you very much. First and foremost, I think I should say that this is a very profound topic. It's been treated at different fora, but it remains interesting because of the impact on quality of life to the average Nigerian. And that is not to say that we don't have problems. A lot of people have highlighted some of the challenges today. I mean, if we're talking about scalability, for example, we have an egregious doctor to patient ratio of about 1 to 9,000 last I checked. And that tells you that technology, innovation, digital innovation is the only tool that can actually bridge this gap. And also speaking from a private sector background, I think Dr. Ifunanya mentioned stakeholder engagement. That's a big deal, especially in our own organization that we try to grapple with. So stakeholder engagement is something that, if properly done, can actually do a lot in improving scale. I'll go into details later, but it's nice to be here to be able to share my own perspective from Viamo and also learn from the other panelists. Thank you.
Thank you very much. Go ahead, please.
Thank you. So something that has echoed through the three previous speakers has been stakeholder engagement in fostering sustainability and scale. I'm going to be speaking based on my knowledge as someone who has implemented a project that has scaled, which is probably one of the largest scaled maternal and child health program in the world, which is Mom Connect. And how was this, what we're able to do is stakeholder management, the ensuring that the government of, the project is being implemented in South Africa. So ensuring that the National Department of Health in South Africa is involved. It's their flagship program. So they have taken ownership of that program, and they ensured that at the facility level, the healthcare workers were involved in the conceptualization of this project. So there was ownership both at the federal level and with the facilities, the healthcare workers as well. They included that link to Mom Connect phrase in their SOPs for the first ANC. So once a patient comes in, once a pregnant woman comes in, they're able to link them to the Mom Connect messaging. So just reiterating the importance of having government involved, having government take ownership, having the people on the ground, which are the healthcare workers implementing this project, have a buy-in, building their capacity to be able to support the project. That's how you can achieve scale. Within 3 years, Mom Connect started in 2014, and within 3 years of implementation, we had reached 95% scale across public health clinics in South Africa.
Thank you very much. That was quite insightful. We've all heard from our four, we've heard from our four panelists. They've given us their insight, what they feel about what the topic looks like. And I think now it's time for us to start asking specific questions. I guess most of them are waiting for this opportunity so they can dive a little bit deeper into what they want to share with us, which is usually very key and helpful. So partnership and funding is what comes here on top of the list. What are the key factors that ensure successful partnerships and funding for digital health innovations, especially in low resource setting. I think without any doubt, it's a no-brainer where this question will be headed to. So Njide, you have all of that experience, partnerships and funding. So this is your opportunity. Please let the audience, let us understand what some of this, I'll repeat the question again. Key factors that ensure successful partnership and funding for digital health innovations, especially in low resource settings. Thank you.
Okay, so first of all, what problem are you solving? We talk about digital and mobile technology all the time, but we have to keep in mind that it's an enabler. You have to have a functional healthcare system prior to layering the digital intervention on. So for us, we have a very clear approach, which is that we intervene in the entire ecosystem. So we focus on demand side financing. We develop a lot of innovations there, which is how do patients pay for care when they're going to the healthcare facility. We focus on supply side quality improvement, which is where we have our safe care methodology. Again, you want the patient, when you've empowered them to go access care, that there's some minimum standard of care that they receive in the healthcare facility. Then you also look at the governance structure. Who is monitoring the outcome of the care that they provide, that they're being provided? How is it quantified, and so on and so forth? Then from the patient perspective themselves, how are they helping themselves, and how do we use digital to empower the patient? I won't say Uberizing healthcare, which is, can the patient be in control of their data, their access, aggregation of funding, and all that using their mobile phone? So for us is, when we articulate all of this, then we look for specific problems that we want to solve. And again, like I said earlier, you start private and grow public. So I'll use one example to explain what we've tried to achieve. And that problem is with the TB detection. Some of you may know that Nigeria is the 6th country with the highest incidence of TB. Maybe we've climbed up the ladder to 4. So, but we have one of the least detection. And why is that? Because of the stigma around TB. People don't want to go into the clinics and so on and so forth. So what did we do? We convinced Global Fund, because all the time Global Fund invest thousands of dollars in Nigeria. And what do is they procure a car, it's always about procurement. And we said, let's test with you a new way of doing things. So basically what we did was we took the paper clinical protocol and programmed it into a feature phone, an algorithm, which you go through the algorithm with a series of questions. How long have you been coughing, and so on and so forth. And behind that algorithm, it tells you whether you're TB presumptive or not. And these feature phones, we disseminated it through community workers into the community, so that you don't even need to go to the hospital to be screened. So we started this about 3 years ago with the funding from Global Fund, partners of IHVN, Institute of Human Virology, and the National TB Program, which anchored it. And I can tell you that at the time when we started, detection was about 19%. Now it's over 34%. And WHO has actually recognized the improvement. So in the last 3 years, we screened over 3 million people. And why is that? Because of a simple tool that was in the hands of trained community workers, and to the extent that PharmAccess is no longer even in the consortium anymore. We've exited, and we've handed the tool to National TB Program. So they've scaled it to all 36 states and the Federal Capital Territory as we speak. So this is just a pure example of how you can achieve scale. Funding started from Global Fund, support from PharmAccess in terms of programming, the thinking through of the innovation, IHVN, and right now there's an impact evaluation that's about to start with KNCV, looking over what IHVN and the partners have done and comparing, because for this kinds of new innovations, you need impact evaluation. So you can then take it to policymakers and say, look, this works. can you institute and, remove the manual process and so on and so forth, So again, this is just a typical example of how you can achieve scale with engagement of different partners, ownership by government, input from private sector, funding from a donor, you bring, and really simple tool that is scalable, it's sustainable, and to the extent that, we are totally out of the picture. So the only input we're giving now is let's help you do the impact evaluation. And that's one success story I can offer to buttress, the points made earlier.
Absolutely. Thank you very much, Njide Ndili. I think that's very insightful. Like I said, I wouldn't be repeating the points. Maybe I'll give a summary when all of them are done. That will be quicker. We'll have time for questions. Maybe I didn't mention that part of the ground rules. So housekeeping rules, sorry. So we'll have time for questions. There's ample time for questions. So because we want this to be very, engaging. Thank you for that. So I'll be moving over I'll cycle back to you, Njide, but for now, I want to move over to Dr. Ifunanya. Now, we have clinical integrations with your wealth of experience in the clinical ecosystem. How do you think digital health innovations have been integrated into clinical practices at any clinics that you want to talk about? What impact have they had on patient care and outcomes?
Okay, awesome. Thank you so much for this question. And just thinking through it, I think I'm fortunate. I sit on two chairs. I think I'm part of the innovation partner and then the implementing partner. So I can talk about this in two ways, right? One of the most fortunate things I have at EHA clinics is being able to have an in-house informatics team, which means that stakeholder management is happening during development. When I first joined, we had an EMR that we figured was not what we needed. It wasn't helping us get data for improvement. It wasn't fit for use. For a lot of the work that we needed to do with JCI, the kinds of things we needed the EMR information to give us, we didn't have that. So we had to go back to the drawing board and ask ourselves, if we buy an EMR off the street, we will still have these issues because sometimes it's just not fit for use. But how can we create something that it's not just fit for our use, but it's easy? We talked a lot about interoperability. It's easy for others to connect different things to it, that the goal is quality and patient safety. And that's why we went on this journey to build EHA Care. And one of the things that, we talked about, we like to talk about EHA clinics is that we focus on the system. We never focus on people. It's very easy for you to say, this thing is not getting done because people don't know how to do it, or this person doesn't want to do it. If you've ever taken, we talk a lot about crucial conversations. One of the things they always says is that, why would a rational person want to do the wrong thing? So one of the first things we talked about was clinical decision support. How can we make it easy for people to make the right patient safety decisions? How can we ensure that, every patient who comes, everybody knows that after COVID, we had a mental health crisis. How can we ensure that every patient who comes to the clinic, we're not waiting for people to attempt suicide, but during the normal primary care visit, we're collecting data to screen and assess patients for mental health. And all of that went into EHA Care and our clinical decision support. Another thing we thought about was, of course, we're getting all this data, but how can we manage patient populations using this data? We have a program called Health Tribe. And in Health Tribe, we have chronic care patients. And are we able to use this data to say, how many percentage of our Health Tribe patients are getting better? Are we able to collect data from these patients at home, right? Okay, so they come to the clinic, they are getting medication, but what's happening at home? Are they taking it? How can we ensure that these patients who we have put into this program are taking medication? And then when we designed HealthMate, we had, a patient-facing app that's able to collect information about blood pressure, blood sugar, and things like that. And one of the things we also saw from the data was a lot of our patients in Health Tribe were not having access to nutritionists. Nutritionist consultations are expensive. So we thought about how can we democratize that? And then we built a program called NutriPlus, which is a web-based application where they can do a free assessment and get access to dietary plans. And finally, very big part of patient safety is diagnostics. In fact, World Patient Safety Day in September this year is talking about improving patient safety through preventing diagnostic errors. And one of the things that we looked at was what are the most common diagnostic errors made? And as simple as an ECG, right? And how can we use artificial intelligence to read ECGs to increase the diagnostic capacity of the clinicians? So those are a few of the things that we've done within our space. Thank you, Abdul Hamid.
Enough time. So sorry if I keep interrupting the conversation. Maybe I might look like I'm the enemy of the conversation today, but it's just in trying to make sure we go around as quickly as possible. Thank you for that, Dr. Ifunanya. I think now I'll be moving over to Mr. Seun Adesina. Based on your experience, I want to zoom in on user adoption for you, because I think that's very relevant to the core experience that you have. What are some of the best practices for encouraging user adoption of digital health solutions among diverse populations?
Thank you very much. So for us at Viamo, I must say that we've struggled with that a lot. And lately, what we're finding is that it's important to be inclusive. Cultural sensitivity and inclusivity is one of the key strategies that has helped us, overcome some of these challenges. So I'll give an example. Viamo was an implementing partner on IHP. And fortunately, when that started, we had a relatively good uptake of the Viamo solution and platform. However, it wasn't scaling as planned. So we had to adapt to fit local content, be more inclusive, take note of the culture, the cultural norms. So for example, in one of the implementing states, it was almost impossible for some of the women to have phones. So what we did in that situation was to get the head of house to give their own phone numbers. So we were implementing a solution called automated appointment reminders. And we realized that if we call the heads of house, they can actually notify the women to come. And that increased appointment attendance by about 45 to 50%. That was one. The second thing was to try to make sure that this intervention was at no cost or very little cost to the people that you're trying to help. So you're trying to help people at the last mile, underserved community. They're grappling with literacy levels, language. So obviously we can't afford, to attach any cost to this solution. So at Viamo, we have a bring your own device kind of policy where we meet you at your point in the journey to technology, basically. And that helped a lot on that project. The same thing happened when we were implementing with Breakthrough Action. Now for that, because most of the content on the platform was curated by partners that we've worked with, USAID and other NGOs, it was important that when they do call into the platform, they're not charged. And that's where private sector partnership comes in. Because we have an agreement with Airtel to give free airtime, they were able to call the platform at no cost. They were also able to speak and listen in their preferred languages. And that was, I think that was the singular reason for the success of that implementation. So again, I'll say it's cultural sensitivity and inclusivity that actually supports user adoption.
Thank you very much, Mr. Seun Adesina. I think that was very insightful as well. So we'll move to Mrs. Chichi Aigbe, Senior Project Manager for REACH. Based on your experience as well, I'm going to pose the first question to you, which is going to be on implementation challenges. What are the biggest challenges you have faced in implementing digital health innovations, and how have you specifically overcome them in the past? Thank you.
Thank you. At REACH Digital Health, one of the most challenging issues that we have had to face is ensuring accessibility and engagement in the vulnerable and engagement in vulnerable and underserved populations. You have issues of internet access, either no internet access or unreliable internet access. You have issues of literacy, digital literacy issues. You have even some places you go to, they don't trust, technology, So one of the ways that we have worked on this issue, addressed this issue, is we've developing user-friendly innovations or mobile solutions that can be used on basic phones, like feature phones, and also as similar to what Viamo is doing, meeting them at the point of their needs, whatever solution, whatever device that they have on hand is what we use. In terms of, I want to use an example of a project that I worked on here in Nigeria. It was called Hello Mama between 2015 and 2018. It's also a maternal and child health project. I think Emeka had alluded to it in his presentation. When we worked in two states in Nigeria, Ebonyi and Cross River states, and there were some areas where, there's no internet solution. In that kind of environment, what you would use, you're not going to bring WhatsApp based or any IP messaging based solution. You tailor it to what it is will work, SMS, and then of course, SMS on its own also has its challenges in terms of costs. Who's going to pick up the cost? Even though it's reverse billed, if it's not charged to the user, somebody has to pick up the costs. So what we did was we worked with the NCC, with the help of the Federal Ministry of Health, to get a zero-rated short code that was used for that project. And so those took care of the cost. So we worked with both USSD and SMS. This also circles back to the importance of having government buy-in and ownership. And even as at the time where the project was implemented, the government of Cross River also had put in their budget for this project $110,000 to support the efforts. So again, circling back to the importance of having government buy-in in the project. In terms of digital literacy, you're working with what they already use. If it's SMS, those are the phones that they already use, the feature phones. If it's WhatsApp, that is what they already use. So there's very little need to teach them of anything because it's already in their hands. For Hello Mama, for instance, we didn't use WhatsApp or anything, but we used SMS and IVR, and we ensured that as part of the health talks that happened during the ANC visits, the healthcare workers, built the capacity. Well, I don't want to say train, but spoke about how, that project will work each time. All right, I've been told to stop. Thank you.
Chichi Aigbe, I think you were really diving into some of the details. Unfortunately, time will not permit us. It always does its job as usual. So I'll be circling back for the second round of questions, and I would like to start with Njide Ndili. I think the next question will be on scalability. You did mention that, I think, during when you were responding to the first question, but this is the opportunity to zoom in. We want to hear what strategies have proven effective in scaling up digital health projects, especially across multiple regions or countries in Africa, based on your experience. Thank you.
Okay, so real quick, some of the experiences. By the way, we are implementing projects in Nigeria, Ghana, Kenya, Tanzania, and I can use the example of SafeCare. SafeCare is a quality improvement tool which we have running in all these countries. One is that, again, we have government buy-in. We're able to scale in all of these countries because government has adopted the standards and implementing it either by legislation or by implementation of some kind of law that enables. So for example, in Nigeria, just yesterday, I signed an MOU with the National Health Insurance Authority for their 7,000 BHCPF facilities adopting SafeCare. So this is an example of SafeCare scaling. I also met with the Minister of State for Health also 2 days ago as well, and SafeCare will probably be included into the national standards for tertiary institutions. Again, this is government scaling. Government is the strategic purchaser. So one is having government buy-in. Two is ensuring that as you're starting your pilot, I said start private, grow public. As you're starting, you're testing it. You must have some kind of impact evaluation or some kind of research behind it, proving your innovation, that either improves quality of care, it reduces cost, and so on and so forth. With that, you have evidence. So it's independently done, not by yourself, so that you have evidence that this is the way to go. Three is that you set aside some funding, if you're an NGO or whatever organization you are, to build capacity of the government agency, because oftentimes they don't have capacity. Another example I'll give you is PharmAccess, the healthcare facilities management in Lagos. It was done with our support and Global Fund. In fact, for 2 years, I had 2 staff embedded within PharmAccess. PharmAccess is now the one that issues licenses. They close your facility or open it depending on whether you meet their standards, right? And now we even gave them or developed a platform for them where you don't really have to renew your license by going into the facility, which was what they were doing before. You can do all that online. And to the extent that I don't remember the last time I got a call from PharmAccess, we've exited. So building capacity of the agency or the institution is so critical, because for sustainability, you have to ensure that they have the ability to carry forward the innovation. 4 is that you have to localize the context across different regions. Like I said, in Nigeria, Ghana, Tanzania, different attitudes, even though it's the same solution, but we try to localize it. So we now do white labeling. SafeCare, any organization that has the capacity can license SafeCare and scale it to the extent that we have, we've adjusted it for NGOs, we've adjusted it for private sector, we've adjusted it for government officials, where you can put your logo and all that. So you have ownership. That is another example of what we're using to scale. But most importantly is that after all said and done, be available to support. So quality is not stagnant. Innovations are not stagnant. So our job really, as we deploy this, we go back and we continue to refine and improve and develop, and we come back to you to redeploy or to offer additional support if necessary. Over.
You didn't allow me to warn you about time. I'm happy about that. I always feel guilty. Yeah, great. So thanks. That was very useful. We hope we have more time to talk about these things, but I have been warned that we have just about 4 minutes or thereabout. So what I would like to do, I will skip you, Dr. Ifunanya. Sorry about that. I want to ensure gender parity. At least we had one female with a second question. Let me skip to the male with a second question, and then very briefly, Mr. Seun. So that rounds it up. Then we give the floor to our for Q&A. Yes, I know we have people that are eager to participate. So for you, Dr. Seun, based on your experience still, data utilization, how can data generated from digital health tools be effectively utilized to inform public health decisions and improve health outcomes? We appreciate if you can be as precise and concise as possible. Thank you.
Okay, thank you very much. So for us, we've seen this done several times across different projects. But one example that comes to mind is the work that we did with Breakthrough Action. And this was around COVID. we carried out a survey to find out attitudes around vaccination and, how people in different parts of the country would react to that. So that kind of feedback from that survey informed a lot of what USAID did in terms of supporting vaccination in Nigeria. The second one is Gen AI. We have our own Gen AI solution that we've been, setting up across various countries, Tanzania, Zambia, Nigeria, and the pilots are running successful. But what is important about these pilots is the information that we are able to get. So I can tell you the 18-year-old girl that calls in from, Maiduguri, asking certain questions around family planning, around sexual reproductive health. And you can, in some cases, have about 223,000 calls on a single topic. So that kind of information helps you make decisions around interventions in a particular state. If we bring it down to the South, we get questions around HIV, what to do when, I don't see my period, and so on and so forth. And we have that for ages 20 to 25. And that also informs the kind of intervention that you'll be expecting in the South or the Southwest. So I think for us, Gen AI has helped a lot in getting data that helps some of our own projects, because like most people have said, no solution is at its final stage, iteration. And that applies to the programs that we're working on as well. So we also use some of this data to advise partners, to advise donors, to advise funders as well. And like I said, with the COVID example, that kind of survey also helps in planning for, God forbid, the next pandemic. How would they react to possible vaccination? So there's that record already to see how different people across different regions in Nigeria would, react to vaccination. Over.
Thank you. Thank you very much. I still apologize once again for putting you folks under pressure, but I think we've done the job. Please, a big round of applause for the panelists. Quick summary. I think we've heard it all. So this is not normally an exciting time when you're repeating what people have heard, but it's a job that we have to do anyway. One of the things that ring bell across all of the panelists is engaging stakeholders as early as possible and engaging them through all stages and all phases of design, co-designing, co-creating, and co-implementation. I think that's key across all of what the panelists have spoken about. Then keep it simple, scalable solutions, and make sure you involve government as early as possible. Then we all heard about interoperability as well. I think even before this session, we've been hearing about that all day long. Then quality improvement from the clinical side, we heard how key it is. You can't improve what you can't measure, right? So that's key. And also make sure you don't rely on false assumptions, because false assumptions will not allow you to scale effectively. Then simple implementations as well, echoing what Njide and the rest of the other speakers talked about. You can even use checklists to help you ensure that you keep things as simple as possible. Then digital innovation is the only way to go. Mr. Seun was very particular about that. It's the only way to go, because you don't have an option. Well, you have, but if you ignore technology or digital, it's at your own peril, right? So you have an option actually, but you suffer the consequences. And then we also heard about stakeholder engagement, re-echoed again, government ownership, local buying. That's what's especially coming from Mrs. Chidi Aigbe, which was very instrumental as part of your efforts to scale digital health solutions. You have to also make sure the healthcare system is functional in the first place, and you also focus on all aspects of the ecosystem. I think Njide is able to talk about this because she controls the work she does. They control a lot of the aspect of the ecosystem, from the demand to supply and other aspects. For some other people, you might not have that control, but nevertheless, it's a good thing to bear in mind as well. Make sure there is governance structure. Then you should start private, and then before you go public, right? And then I think that she talked about SafeCare. We heard one or two things, beautiful things about SafeCare, how it was able to scale to 3 million people and so on. Then in-house informative team. Not everyone is able to afford that, but I think that was helpful for Dr. Ifunanya. That ensured that all of the early stakeholder engagement happened because the team were sitting right under her. probably they are reporting to her, someone even reporting to her. So she had that comfort or luxury. Other settings, you might not have that. Some people are small organizations, they need to outsource their informatics needs. Quality and patient safety is key. I think for the EHA clinics, that's why EHA Care was developed from scratch. And then you also need to focus on systems, not people. I think that was a key takeaway as well. Then cultural insensitivity, or cultural sensitivity rather, and inclusivity. This one should have been a hashtag. Where are the media people? I think I really like that. So cultural sensitivity and inclusivity, great point. That was from Seun Adesina. So, and also he talked about how to support as much as possible. I think Njide also mentioned that support freely, don't attach cost. You are trying to scale, make sure you support the government, train them. She even went ahead to say how they deploy people resources free of charge to support government. It's something we have to do, unfortunately, whether we like it or not. I don't want to talk about EHA. It's something we also do from our side. Then attitudinal check, I think that was helpful also. This coincides with the vaccine hesitancy, for instance, right? Is at a hesitancy level within the community. It might just end up failing a failed project. So I think I agree with that. Attitudinal check is something we also do before we go into campaigns. Generative AI, that's usual technology coming in handy now. Njide also gave an example of how they use the technology for TB and the rest. Then from Chichi also, there's accessibility and engagement in vulnerable and underserved community. That's always an area of focus, and make sure you create user-friendly apps that are also adaptable to the populace. They don't go and bring apps that work only on iPhone, and then you are going into communities that are underserved. They can't even afford, they are just barely affording feature phones, right? So those are things that you do. Then you need to support with data as well. In our own experience, we also find out that even when you give data, you have to be patient. They will use the data for other things beyond what you told them to use it for. That is for sure, 100%. So, and if you lock the phone down so that they can't use it for that, they won't do your project as well. So what we have learned over time is if we need to give them 2 gig, we lock down 1 gig and we give them 1 gig free. So that 1 gig, they use it for their free stuff, and then at least it encourages them to use our own 1 gig for our work, right? So those are the kind of steps that we take. Overall, I think I can go on and on. It's a very helpful conversation. Yeah, thank you very much. Thank you very much. Yeah, that goes to my distinguished panelists. Another round of applause for them, please. Thank you. Yeah, I'm sure our question and answer are very engaging audience, and we will need to apply equity once again. 2 questions from in person, and then 2 questions at a time from online. We'll be cycling that way till time catches up with us, and try to be as gender balanced as possible, please. Female, we are highly encouraged to participate. So we'll start from in-house. Who has a question? And the rule is please try to be very concise. And if you want to direct your question to any of the panelists, do so. If you don't do so, we will assign to any of the panelists for sure. Go ahead, please.
So thank you very much.
Yeah.
My name is Dr. Omar Churuma. I'm from Yobe, the incident manager from Yobe State. Yeah, I think since morning we understand that digital innovation, especially in Nigeria, have been at the slow phase. And this will be, may not be unconnected to the fact that everything is even centralized. So the question now is, I don't know whether I can make it to Njide or so. The question referred to her or any of the panelists. Was there any experience with regard to subnational engagement process in this drive? Because we know in Nigeria, we are running into republic, and all tiers of government has its own responsibilities. So I don't know at the subnational level, can we have that kind of arrangement, like MOU arrangement and whatever it is, that will also cater for this scale up processes so that it will help us. I think the other one, maybe the second question is the issue of health package in terms of digital health services. All along, we know we are working, especially me, at the primary healthcare level. I know some of the examples cited, like notary bags and all other things have been the improvement in terms of digital innovation. So I don't know in the integrated PSC services, is there any other component? Because most of the innovations, most of these in an area of immunization, nutrition. So I don't know at the primary level, is there any other areas that we think progress has been made within or outside the country that also subnational can copy and also have that kind of understanding with all the relevant stakeholders? So thank you very much.
You just go ahead. This question is already been directed. Yeah, thank you.
Okay, so I'll answer really quickly. So you say you're from Yobe State. Incidentally, we are also in Yobe State through the IHP project. And currently, we are developing a regulatory platform for Yobe State, which was done in one of the other IHP states, but being cascaded to the other IHP states. So in terms of scaling up, first of all, again, the funding came from USAID with partners like us and Viamo who are doing different things. So everybody has a different part to play, but the whole emphasis is how do you empower the government officials to take over, which is why that regulatory platform is being developed. So there is engagement, but unfortunately is not as robust as we want it to be. And we can only work as quickly as the state is willing to learn, the state is willing to take leadership, because again, you have to say what you want. What are your priorities? Otherwise, there are too many priorities, and then we take it on from there. So unfortunately, the project closed earlier than we thought, but it appears there's a second round. So hopefully we'll drive down to other areas, but the whole objective is UHC through the primary healthcare system and using partners and private sector to engender adoption and scale. Thank you.
Thank you very much for that response. Do we have, well, I'm not seeing the hands. Okay, great. Go ahead, please.
Okay. Thank you very much, panelists, for that wonderful session. I have one question, which is about the topic itself. So it's good that we are talking about scaling up digital innovation. We know innovation is all about solving problems, and the health system in Nigeria is presently being ravaged with a lot of issues and challenges. So a lot of levels of healthcare system have not been reached yet. So what are we doing to actually reach those that have not yet been reached with digitalization of public health services? So the second one is not a question per se, it's a comment, or let me say a kind of recommendation for those of us who are partnering in the aspect of digital innovation. So you've said a lot about stakeholder engagement, and we really, coming from implementers angle now, we really need to go beyond capacity building. When you build capacity, also ensure that these capacities are being stepped down to other people, because resources are not enough to train everybody or all the health workers in our area of focus. So when we step down training to other people, so other health workers, this will serve as a kind of legacy you leave behind. And considering the current situation of massive exodus of doctors and nurses from our health system, so the person you train today might not be there tomorrow. When you come back, he has already japa. Then the next thing is to start sourcing out for another person. So that is one thing I would like to add to the sustainability aspect. And beyond this, we should also take advocacy to those of us that are policy influencers and policy makers, to the extent that we should sit with them at the planning level. Because what we experience in the field is that different partners bring different digital innovation and all that. And by the time the project closes out, everything dies off. So there is no budget line created in the government and leadership's aspect, building block of the health system to continue. So you now begin to wonder, with all these resources spent by this partner, so how do we overcome this? Thank you very much.
Yeah, I think she didn't direct it. No, we'll come to you. Questions one by one. Thank you for that. Lots of questions here. I think I was able to glean a couple of questions. Let me start with Chichi. I think you didn't even get to have the second round of question. So let's try to balance that now. So she's talking about, you heard her question. Anyone you want to talk about? What are we doing to reach those without digital infrastructure, the digitally disprivileged, right? What are we doing? What efforts are we doing? Then stakeholder engagement, beyond capacity building. How do we ensure we cascade the training? And she also added another valid point. You cascade the training and the person japa. Then what are you going to do again? Where do you start from? So you can take anyone that you want to take. Then I think Dr. Ifunanya can take the second one.
Okay, I'll take the second one because, yeah, because there's a reason for that. Most of my projects are not in Nigeria, so I'm not sure what is being done on the ground currently for that. So in terms of, capacity building, for the implementers and at the facility levels, I totally agree with you. It's very important to ensure that there's no bus factor, but it's kind of difficult, especially when with healthcare, because you're training people. So even if, there's documentation available, so that's one of the things I would say. Ensure that at every point in time, whatever training that is done is documented so that it doesn't stop with that person. Whenever there's a leaving, then there's a proper handover done to whoever is, going to take over. In terms of the brain drain, unfortunately, I don't know what we can do about it, but I believe that medical schools are churning out, and nursing schools and all that are churning out graduates on a yearly basis. So it's just having the people who are willing to come to those areas to work. And that is something that the government needs to address. But, I would say just ensuring that at every point, whatever capacity is being built is documented, and there's a proper handover done so that the next person can take over.
Very much, Chichi Aigbe. I think next question. Yeah.
And I don't know if it's okay if I can start from what Dr. Chichi has just said. Of course, healthcare, everybody's jabbering, and one of my greatest frustrations is having to train doctors over and over and over again. And I think one of the solutions is probably using digital health innovation, and I'll tell you why. Let's make the system so simple, so user-friendly that I can create a training program online that somebody who comes new to the organization can just go do the e-learning module and we start. One of the things that we saw that was easier, with building capacities, building it from the beginning. So as a doctor is leaving, as I'm employing a new doctor, I have a very specific 2 weeks onboarding period that says, these are the things you need to know. These are the things you need to know. Go through this program. This is what you need to know. These are the things that will make my system work. 2 weeks, I test to make sure that you can. I test again in 3 months, get it working. That's the only way, because if not, I can't count how many doctors I lose, every day. And just saying that maybe, looking at primary healthcare, that is where to build capacity. As people are coming in, let the process not be another process. Let it be the system. One of the easiest things I've seen is the easiest way to implement an SOP is to make the SOP the system. Not to say, oh, you need to go and read this SOP. No, at EHA clinics, this is how we see patients with UTI. It is the system. It's, trying to learn 1 million SOPs, trying to go through how many process, just make it so foolproof that even if you wanted to do the wrong thing, the system wouldn't let you, right? And, talking about what we're doing with primary care and how we're looking for how to scale these digital health tools. I mean, beyond our private practice, we looked at it and realized that healthcare should be democratized. Quality healthcare should not only be for the haves. So how are we taking that to the community? And we came up with our REACH program. And now we're scaling our REACH program with other primary healthcare facilities in other states, who are ready to partner with us, build PPPs, and we're able to be using the system that already works. It's just plug and play, able to go there, implement, using their own staff, and even make quick decisions. And they've given us, for some of the states, given us a lot of laxity, which is if it's not working with this person, just keep it moving. So definitely willing to partner, because we know that the capacity, there will be a percentage of patients who can access our clinics. But if we really want quality healthcare in Nigeria, we need to partner with primary healthcare, because whether you like it or not, 85% of what a patient needs will happen in primary care. Our teaching hospitals are already overstretched. People have cough and catarrh. Why are they going there? So we need to make primary healthcare the option, and then have that effective referral system to tertiary care. Thank you.
Thank you very much, Dr. Ifunanya. I think that has done justice to the two questions. Principle of participation equity. So we'll be leaving the in-person audience now. Apologies, please. Who is in charge of online? No question. Oh my goodness. Okay. Okay. Yes, cycles back to the in-person audience then. Okay. Yes. I think the mic is there quickly.
Thank you very much. Good afternoon, everyone. Thank you to the panelists and the moderator for an awesome session. My questions are on these two fronts. I am Dr. Muknan Inshe. I work for CHAN as a program manager for the Race for Sahel program, which provides access to routine immunization to communities in humanitarian setting. And that forms the basis for my first question, talking about digital innovations and all that. How do we maximize the data that we get from the humanitarian setting and from communities that are underserved? A lot of Nigeria has become quite unsafe, and a number of information is lost from that. How do we strengthen data management from that system and deploy strategies that will cover for populations in humanitarian setting? The second thing is around how do we generate and synthesize data from the faith-based communities? Quite a number of the population of Nigeria are served from the angle of the faith-based hospitals and facilities. How do we engage those population and use them as critical stakeholders to strengthen the innovative approaches that we deploy in service delivery and for digital transformation? Thank you.
I think I would like to pass this on to Njide, if you don't mind. So help us do justice to these two questions, please. Thank you.
That's a very difficult one. As you were speaking, I was thinking already, whose responsibility is it? And I can almost assure you that most of that community is not on the map. They are not seen. So then, nobody knows about them from the government point of view. So again, the responsibility should lie with government, the ministries of health, for them to somehow harness that data. I don't know if there is a mechanism how that data is being collected, that it can be integrated into the ministries of health within those regions. I think it's something that needs to be highlighted, or something that we need to interrogate. Just to circle back to the lady that spoke earlier about budgets and budget lines, because it all stems from there. If the government, and I'll give you one quick example before he stops me. There's a state that we're working in where we've been supporting the state, and when we support, we also go all the way into the legislation. That is, where is your law that says so and so, your mandatory health insurance law for health insurance, Where is your budget line in terms of how much have you designated to replace my staff who is currently working with you because they're not going to be there forever? We ask for those specific lines, and we organize meetings that brings together Ministry of Health, Commissioner, Ministry of Finance, and there was also another ministry, primary, different agencies. And in one of the meetings, we realized that you put it in the budget, and because finance doesn't understand, they don't even release the budget. So it's dead on arrival. So there's a need for interministerial collaboration to make sure that what is put in the budget is released so that the government is able to work. So part of our advocacy as private sector and developmental partners is to play that role. So you have to find a way to convene the different stakeholders to be able to, address some of, or even identify some of those issues, because some of them are not even aware. So in terms of, this issue that you raised now, unfortunately, it may be falling through the cracks. It may be under BHCPF. It may be under, the indigent program, vulnerable group program, but who is coordinating? And that's where the coordination mechanism, governance structures, and so on needs to be put in place. And you can only do that with technology, unfortunately, because otherwise it's on paper, it means nothing. We have data graveyards. That's a new word for your dictionary.
Thank you very much. Yeah, I like that. I think that was very, very well justified. I think the points are well known. Sorry, we skipped you the last time, so I think you can go now. Yeah, sorry. Oh, okay, the mic.
Good afternoon, all. Thank you, the panelists, for these insightful discussions. My name is Usman Ganabil Kadir. I'm the National Incident Manager for the polio program in Nigeria. We all know digital technology is to solve problems. My concern has been this. Over the years, projects come. XYZ innovation in Lagos, in Sokoto, in Kano. And then after the project, finishes, you don't hear about it. If you go to other clients, they have digital solutions that are cut across the country. For Nigeria, as time to be corrected, there is no single digital solution that we can say we have as a country that we are going to launch on and use. For example, let's say for PAC. So one single one for all PACs in this country. A lot of funds are being, expanded into isolated projects. We'll go into Kano, Yobe, you do this. And I mean, if you go to Yobe or Kano, it's not in all the LGAs. It's just in the circumscribed LGAs. And here we keep talking about innovation, yet it's not solving our problems. So I think, so what is the issue? Why over all these years has Nigeria not gotten a single digital solution? Thank you. I want to stop there.
Yes, that's a very, very, very important, a difficult question to answer. I'll know that even before I pass this on to the panelists. Yeah, I know that for sure, but it's a very critical question. Some of the conversation we had today was even centered around that's disparate systems in isolation and so on. So I don't want to be the one that try to answer the question. So panelists, who wants to attack?
Vested interest is the word. In fact, I've been part of several huge, heard about ENHIA, you heard about, so where to be able to run with this, first of all. When you talk about vested interest, you have over 10,000 proposals and everybody's solution is the best. So it's not being evaluated based on the merit or its availability to scale or and so on and so forth. So, I have to say that I'm very delighted I mean, for those who were at the Africa Digital Health Summit, you must have heard the Minister of State. He spoke very brilliantly about his ideas to digitize the health system, starting from the PHCs. I mean, I think it's a huge task, but it's an idea. You start from an idea with an objective, with a goal, then you move from there. And he has also said that he's not going to organizations to do that because Nigeria is huge. Nigeria is literally, and even the way we are designed, 36 countries. Everyone is doing something different. So again, you have to ask what, whose role is it? Is it government? Is it private sector? Is it developmental partner? Which again is why we say start private, grow public. But at the same time, colors. UHC is not one solution. A lot of countries have tried different one system. Can we have different, all the things that work, is there a way to aggregate them and stitch it into this one coat of many colors that, at least let it perform its role? Because if you start looking at that one system, the infrastructure you have in Lagos is not the same as Kano. What you have in Gombe is not the same as in Adama. We've worked in quite a number of these states, and we know that it is extremely, extremely difficult. Different human beings, different cultural practices, different levels of literacy, just so many different factors to consider. So hopefully we'll get there someday. But I also think that the telcos can play a major role. And sorry, give me 1 second. If I give you the example of what we've deployed in Kenya, which is what forget his name, George kept referring to as Kepe. In Kenya, it's called Mtiba. Mtiba is a health wallet, but it's a partnership with M-Pesa, okay? Mobile money platform, which created a wallet in the phone. So overnight, we have 4 million users of Mtiba, which is a health wallet. So you find that in Nigeria, there are 250 million active phone lines. What are we doing with it? So these are the common denominators. Can we innovate around what we already have in our hands, systems that are already existing? But then again, the law doesn't allow you. There's a CBN law that says you cannot buy health insurance using data. You must convert the data to Naira before you buy, because the original idea was, can we be deducting 1 Naira or 5 Naira from the data that they recharge every day, to be able to pay for health insurance? But the policy, one policy killed it. So again, where do we go? Vested interest. So anyway, I'll round up.
Yeah, thank you very much. Yeah, I'd like to add a point to that before we round up finally. On this, I think Njide rightly struck a neutral note. I don't think you were too optimistic that we're going to get there. Maybe you're a bit more realistic than myself. Yeah, just to add to that, I think there are efforts. Maybe a good starting point is not to create one single system, either across the nation or even at subnational level. The first thing will be to create an exchange, right? Go use your different systems, but let's have a connection point. Just like I think it was George also that gave an example of NIBS. We have NIBS for banking sector, right? Each bank operates different system platforms, but there's that connectivity that NIBS provides. If we start with that, that would be good. And I'm also positive, I think you were there, I think, Njide, at the Africa CDC transformation strategy as well, digital transformation strategy at Kigali, we were there, right? So there is the effort also to streamline applications African-wide, continent-wide now, not even Nigeria. So that drive, why I believe very much in that drive is it's taking all stakeholders along, because the donors by the end of the day are the ones sponsoring most of this digital application. So part of the mandate for the Africa CDC transformation strategy is to ensure that no new digital solution is being created. There is a repository that was agreed on then, a repository of all existing healthcare digital applications. So what we should be doing is consolidation within existing solutions rather than bringing in new solutions. So you see, if donors key in, because if donors don't give you the money, no matter the crazy idea you have, if you want to bring thousands of applications, you don't have the money, right? So if the government also is there, every stakeholder was well represented. That's why I'm very hopeful that with that drive continentally, we are moving towards streamlining applications. And then also, like I said, if we create the exchange, we will have taken 2 big steps towards this. Not that I'm over optimistic, I agree with Njide, but at least I'm just putting it out there that there is room for more optimism probably. Yeah. Thank you very much. Round of applause again for our moderators, our panelists. Thank you. Thank you.